Dear friends, dear colleagues, I would like to start with the expression of thanks to the organizers. Although the title was a real headache for me, it is an attractive but very tricky title. It sounds good, but it is not really clear. What does it mean? Negative evaluation. What kind of evaluation is negative? Was it performed by pediatrician, emergency specialist, syncope specialist? Was it a primary cardiac evaluation or advanced cardiac evaluation or a non-cardiac evaluation? Therefore, in my talk, I would like to share with you how the structure of care determines the meaning of negative evaluation. What are the helpful red flags and score to diagnose cardiac syncope? How to evaluate these red flags, and what happens if even cardiac evaluation is negative? Basic evaluation consists of history taking, physical examination, and ECG. If it is positive, so there is a suspicion of cardiac syncope, then cardiac evaluation is needed. If it is negative, the patient will not refer to the cardiologist. It means that if the question in the title is related to basic evaluation, then the answer is relax. But the real life is different. In most of the countries, even if the red flags for cardiac syncope is negative, patient will be referred to cardiologist. Also, if the circumstances are also not typical for neurally mediated syncope, seizure, psychogenic syncope, etc. Briefly, atypical syncope is also referred to cardiologist. So if the question in the title is related to atypical syncope, then the next to do is reconsideration of basic evaluation, reconsideration of red flags, and workup for abnormal history, physical finding, or ECG. You all know that syncope as symptom can develop with several different mechanisms in the background. Most pediatric syncope is vasovagal, but cardiac origin and neurologic seizure should be differentiated from benign, neurally mediated syncope because of their clinical significance. There are some circumstances, so-called red flags, which reflect to the etiology or at least raise the suspicion of specific etiology. In order to quantify the level of suspicion, Del Rosso and his colleagues elaborated a score, the so-called EXIT score, to diagnose cardiac syncope in adults. Name comes from the name of the study, Evaluation of Guidelines in Syncope Study. The score consists of several clinical variables like palpitations, abnormal ECG, effort syncope, syncope in supine position, neurovegetative prodromes, and predisposing factors. The interesting point of the score is that abnormal ECG, neurovegetative prodromes, and predisposing factors are also defined, and points with negative value are also used. The score was validated in adult population, and we tested with my colleagues the sensitivity of EXIT score also in children with channelopathies who were presented with syncope. We focused on the diagnostically most challenging subgroup of cardiac syncopes, on the arrhythmic syncope, due to channelopathies. Physical examination of a patient with cardiac channelopathy after a syncopal event is unremarkable, making the prediction more difficult for a general pediatrician. Contrary to these, congenital structural heart diseases, cardiomyopathies, pulmonary arterial hypertension are more affluent in signs. Description of syncope by the child or an adult witness, was available in 8 of the 13 cases. The most typical cardiac warning sign, red flag, was F4 syncope. However, somewhat confusingly, warning signs considered typical for epileptic seizure or neurally mediated syncope, like clonization more than 15 seconds and autonomic prodrome, respectively, were similarly frequent in this patient group of arrhythmic syncope. Multivariable EXI score was calculated retrospectively for the presenting syncope, and it suggested a cardiac origin, more than 3 points, in 7 children, which means 88%. One patient who was not identified by the score had a medium probability of having long QT syndrome. Regarding the evaluation of atypical syncope, the next step is workup for suspicious basic evaluation abnormality. If the suspicion of congenital heart disease arises, echo is the next step, searching for structural abnormality. If syncope occurred during exercise, it seems obvious to perform an exercise test to look for ventricular ectopy, especially for bidirectional couplets or bidirectional VT. If there is a remarkable history of syncope, sudden cardiac arrest, or sudden cardiac death in the family history, affected family members should be also investigated for cardiac syncope. If the ECG abnormality is clear, then decision about next step of evaluation is easier. But in borderline cases, you can need provocative testing or even loop recorder to prove relationship between syncope and arrhythmia. If history, physical examination not typical for cardiac syncope, ECG, echo, exercise test, Holter, cardiac MRI, EP study negative for cardiac origin, we can again relax. Or we can consider implantable loop recorder. According to adult guidelines, if the mechanism of syncope is uncertain, but the arrhythmia is very likely, the implantable loop recorder has a class 1 indication. Clinical experience with implantable loop recorders in children was published by Czozek and co-workers. They reviewed medical data of 116 children with implantable loop recorder implantation. 79 patients had a syncope as indication, and 68% of them could be a recurrence of syncope documented. ELR efficacy was similar regardless of the indication, although patients with non-syncope indications had a higher frequency of ventricular arrhythmias, as opposed to asystole and heart block in syncope indications. Concerning atypical syncope, what else can we do? Hematocrit, hemoglobin should be investigated if hemorrhage or anemia is suspected. Toxins, blood sugar, blood gas should be tested if toxic exposure, hypoglycemia, or hypoxia is suspected. The emergency clinician must verify that teenage girls who report no sexual intercourse are really not pregnant. Troponin and D-dimer should be tested if cardiac ischemia-related syncope or pulmonary embolism is suspected. Home video recordings of spontaneous events should be considered. Physicians should encourage patients and their relatives to obtain home video recordings of longer-lasting spontaneous events, especially in case or in of psychogenic syncope. Psychogenic syncope frequently occurs in times of stress or high emotion and is unlikely to occur in children under 10 years of age. These psychogenic episodes may be a manifestation of underlying conversion disorder. Self-resolving syncope that lasts longer than 10 minutes is unlikely physiologic and likely suggests a potential psychological etiology. Psychogenic syncope almost never lead to injury and can occur in supine position. Differentiating syncope from epileptic seizure is very important. Syncope has very often specific trigger, while epileptic seizure rarely. In case of syncope, myoclonus starts after the onset of loss of consciousness, but in case of epileptic seizure, the onset mostly coincides with loss of consciousness. Duration of loss of consciousness and confusion after attack is much shorter, only seconds in most syncope, while in case of seizure, they last minutes. Presence of myoclonus and incontinence by themselves are features with limited utility. If basic evaluation is negative for any non-cardiac obvious reason, but cardiac red flag is positive, cardiac referral is mandatory. If loss of consciousness lasted more than seconds, neurological referral is needed. If syncope was precipitated by sudden or sustained standing, orthostatic syncope is likely. Otherwise, vasovagal syncope. Summarizing my talk, anarrhythmia should be considered in all children with syncope. ECG should be obtained in all children at least once in their life. Most of the rules regarding limiting extensive testing presume a normal ECG. Most pediatric syncope is vasovagal, but cardiac abnormalities can easily be overlooked. A thorough history is the best strategy to determine the cause of syncope and guide further investigation. That is why every new level of evaluation starts with reconsideration of clinical features of syncope. Positive orthostatic withers do not rule out the causes of syncope. That's why I didn't speak about tilt-table testing. Extensive testing in low-risk groups rarely improves diagnostic yield and results. Anytime there is cerebral hyperperfusion, convulsive movements are possible. This is known as convulsive syncope. This is different from epilepsy, as the myoclonic movements occur after loss of consciousness and tonus, instead of at the same time as syncope. Persistent neurologic deficits or failure to return to neurologic baseline are red flags that indicate etiology more serious than benign syncope. A family history of sudden death could suggest a genetically inherited cause of cardiac syncope. Thank you for your attention.